I'm here to provide options. I'm here to act in your best interest as a patient. I'm here to listen. When we've exhausted these more conservative, conventional approaches, I don't want to give up on you. So I have these other treatment options that work better for your behalf. So it really is a relationship that I'm trying to build with my patients.
Welcome back to the Injury Pros podcast. I'm Steve DeBonis from Cordisco Saile. And today we're talking about something that comes up in nearly every single personal injury case. I'm joined by Dr. Sam Grodofsky, a respected pain management physician here in the Philadelphia area. Dr. Grodofsky works with injured patients every day, helping them manage pain, restore function, and get their lives back. Welcome, Doc.
Thanks, Paul.
So jumping right into this, we were talking a little bit off screen as we tend to do before these things start about how pain is ultimately the number one reported symptom after motor vehicle crashes, even when fractures aren't present. Now, the studies consistently show time and time again that early intervention in pain management reduces the likelihood of chronic pain. However, still though, individuals delay pain. Talk to me a little bit in essence of the importance on just swallowing the pride, swallowing what they're telling you, and getting that treatment sooner rather than later.
Well, thanks for having me on the show. I see patients in my practice. I'm the medical director of Philadelphia Smart Pain and Wellness. I treat pain on a daily basis as part of my specialty. And the way I look at myself is I'm trying to treat the person and the whole body, not just a specific condition. And so, yes, patients come in and they want to be tough. They want to be strong. We live in a society of being stoic, but when you're coming to me, it's time to get better. It's time to help me, help you, and understand what your body's telling you.
So you mentioned you're treating pain every day. You're seeing people at their lows of low, and it's the most questioned symptoms after an accident. From your medical perspective, why is it so often misunderstood, I should say, even when well-meaning people?
Pain's invisible. It's something you feel, you experience. It's not a broken bone. It's not a burn. So there are underlying structural problems that can cause pain, and sometimes there's just damage to tissue that is just at the microscopic level. And so it's my job to really get at the root and treat the pain at the source.
So talk to me a little bit about how you are able to evaluate if a person's actually in pain. And as people come in, and I'm sure even on their worst days, their pain threshold may vary. Their pain may be communicated in a way that's not the best way. We're all learning how to communicate in this day and age, and people communicate differently. Is there certain trigger words that you're looking for? Is there certain symptomology? I know from where I stand, we always want to see spasms. Spasms is always a good thing because you can't fake a spasm, especially if you're palpating the area or something of the sort. Is there something when you're like, all right, there's a red flag here. This person's not telling me the truth, or maybe this person's missing the mark?
Sure. Well, I'm a patient advocate, and I'm my default is to help my patient get from where they are to a better place. If they don't want to get to a better place, right, then that's probably going to come off somehow, but not necessarily in how they talk, but more about their actions. And then even then, I'm not here to try to, do a lie detector or anything like that. I'm trying to help them. And, sowing doubt into whether a person is telling the truth or feel in what they're feeling, that's the best way to harm a relationship. And so, when I am doing a intake and understanding a patient's source of pain, a lot of it comes to my knowledge of anatomy, and kind of overlapping what they're telling me with our understanding of anatomy, which is the nervous system, different muscle groups. So that's, a big telltale. Doing the physical exam, helps reinforce that. And then just getting imaging studies that further helps that along as well.
So let me ask you, and it's always wondered me, why does pain not show up right away? A lot of people say adrenaline. Some people say they're trying to tough it out. They don't think it's that bad. Is there anything that you see in your day-to-day operations that kind of shed light or make more clear of why the pain is delayed, why it's not as severe or intense as, say, the day of the crash?
Yeah. So after the crash, you're in survival mode, and your body starts these pre-programmed processes that are just trying to help you escape danger. We talk about adrenaline, but I actually don't think it's adrenaline that makes people not feel the pain at that time. I actually think it's part of the neural network or the nervous system that's filtering out the pain so they can focus their awareness on doing what they have to do to not die, right? So that's what's happening in the first stages, day 1, day 2. You're not feeling that bad. Then a couple of days later, pain comes with like an invoice, and it's time for you to feel what happened to you in that trauma, in that accident. And so, it's really fascinating how the body works that way. Adrenaline plays a role, but if adrenaline was blocking the pain, adrenaline would be medicine to treat pain. Sure. What I specialize in, my background is, and maybe we can get into this. In my background, as a pain doctor, understanding the musculoskeletal aspects, but also the nervous system aspects of medicine. Part of what I do in my practice, in addition to, treating the pain at the source through procedures like injections, I'm also treating awareness, treating consciousness, treating the mind and the mind's body connected to together. And I do therapies such as ketamine infusions, or psychedelic therapy is something I've integrated in my practice because I am so fascinated by the mind and consciousness overlap with the physical, the body.
So peeling that back a little bit, you said a few interesting things I want to touch on. The first being pain comes with an invoice. At what point in time, and this will correlate, I think, with your methodologies in a sense of when things are appropriate, injections versus ketamine versus the psychedelics. At what point in time when that invoice arrives, is it time that you got to pay the piper, in a sense of ultimately what symptoms or traits at a certain point where, hey, this pain might not be temporary. This might be a permanent fixture of my life that I need to address now.
Yeah. Part of my mission in early treatment is to try to prevent it from becoming chronic. And the best way to do that is movement mobility. Okay. So you get in the accident, you have the survival mode, then the inflammation starts kicking in. And I think it's okay to rest for maybe day 1, day 2, day 3. But one of the problems is that when you start feeling that inflammation from the damage that was caused by the trauma, people feel that they're hurting, and they think that hurt equals harm, and that movement and exercising and putting pressure on the area is somehow going to further damage what was done.
When you say movement, are you talking more physical therapy? Are you talking about those particular things?
Correct.
Okay.
Correct. So a lot of times after the initial traumatic incident, if the pain is that severe, we're getting studies like an X-ray. We want to make sure there's no broken bones. If there's a broken bone, you're going to treat that. It's either going to be told that you have a broken bone, casted, surgery. That's what you're going to find out in the first couple of days. When you've learned that your bones aren't broken, it doesn't mean that you're not hurt, okay? Because obviously you're hurt, you feel the pain. But a lot of that information should be that you should feel competent to start moving, start doing therapy, start seeing the chiropractor. Why? Because then you want to promote the healing phase. You want your body to damage the tissue that was been disrupted. And the best way to do that is through circulation. The more you move, the more blood flow that's going to the injured area, the more your body's cells naturally repair that damaged tissue.
So at what point in time are you then turning the page and saying, all right, this conservative treatment, as many times as it's done in my field, or this non-invasive, then needs to become invasive when we start to talk about trigger point injections, epidurals, ablations, radiofrequency ablations, and all that other stuff.
Sure. Well, so I mean, the generic answer to that is everyone's different, but the way that the typical approach is, right, you want to treat conservatively first. You want to start moving. You want to give your body a chance to heal before we're, putting things into your body let's start with medications, pills. I think, over the counter, muscle relaxers, just to keep you moving. Okay. We want to treat your pain so you can be moving. If that's not working and it's a couple weeks, 2 weeks, 3 weeks, 4 weeks, depending on the severity of the pain, depending on how immobile that you are, if you're not seeing progress, at that point, that's when we start thinking about treating the pain at the source, which is what we do with injections. And it's usually in the beginning, corticosteroids, which reduce inflammation.
And for the people that are listening and the people that aren't familiar with this, talk about what that procedure is the cortisone injection as it pertains to what it's actually doing. Is it a pill? I know this, of course, I know the answer, it's not a pill, but how that kind of works and plays out in your world.
Yeah. So in my world, it's all about accuracy. And we want to get the medicine to the source of the problem. Now, the reason why we need accuracy, because the steroid medication, which is works by reducing inflammation, right? The pain is coming from inflammation, so we want to reduce that inflammation and the feelings of pain. We want to get it as close to the problem as possible so we can give you the lowest dose possible to reduce any side effects. And there's not a lot of side effects with steroids, but the way I do it, is with using usually an X-ray machine, sometimes ultrasound. It really depends on the area that's triggering the pain, and that's based on my ability for evaluation, exam, and reviewing everything to understand where that's coming from. And the goal isn't for me to fix the problem. The goal is to get you comfortable so you can stay moving and active and allowing nature to do its work, which is repairing the damage.
So a lot of clients that we typically have will go in and they'll get that cortisone injection and they'll say, Steve, I felt great. I felt like I was 20 again. I felt like I was 18 again. I was doing backflips. And then you know what? It was like a Band-Aid and it wore off. Pulling back the veil a little bit, talk to us a little bit about how or why that happens, especially if you feel so good after that injection takes place. And obviously medication wears away, but is that a sign that the pain is going to be extended for a long period of time, that these are now just a matter of course that need to be done every so often? How do we kind of understand that just because the cortisone injection didn't work, or it worked for only a limited period of time, what our next steps may be? Does that kind of have confirmation for you that, hey, this might be a more severe injury than we initially thought, or we're not close to the source?
Yeah. So the initial response of going from really bad pain where you're going to let a doctor put a needle inside you, right? You're not doing it if you're in a little bit of pain, to, it takes about 1, 2, or 3 days for the steroids to work. And then when you're going from in a lot of pain to sometimes no pain or less pain, right? You feel great. But I didn't do anything to fix the problem. I gave a chemical in the body that's safe, but it gets metabolized and leaves the body. But the injury's still there. You haven't fully healed the thing. You haven't fully healed the problem. And you also haven't strengthened the muscles around the area to help you live your normal daily life. You need more time. The healing and rehab phase, we're talking about weeks to months, whereas the injections usually work in a matter of 2 or 3 weeks. So, it really depends on the problem. Depends on the studies that we ordered, the severity of the injury, where we go from there.
So I hear a lot in my practice that the patient gets an MRI, because you talked a little about X-ray, which spurred a thought. They often believe that if an MRI is normal, that their pain must not be real, or medically speaking, they feel as if maybe they're exaggerating, or maybe they feel that they're not being believed. How many times out of 10 patients that you see is there nothing in the MRI, a bulge, a herniation, or any even degenerative disease that you're seeing from an MRI? How many times does that actually take place in your practice, where many times you're just treating subjective pain versus objective findings?
Sure. An MRI is a picture. Pain is like a movie, right? It's more dynamic. There's lots of moving parts. An MRI can show structure, alignment. It doesn't show nerve irritation. It doesn't show microscopic tears in the muscle fibers. There's also findings on MRI that have no use and no correlation or no relationship to why you're having pain. So it goes both ways, where an MRI might not show the specific cause, or an MRI might show something, but that's not causing your pain. And the way I explain to those patients is they'll say, "Oh, doc, I have a disc bulge," which is a change in shape of the cushioning in the spine. And I'll say, "Well, I don't think that's the source of your pain, or specifically, if I injected that disc, you're not going to feel better. Instead, based on treating you, I think your pain is coming from a joint." And, and I look at the MRI, and sometimes the radiologist may not comment on an abnormality. So it's always important to bring your MRIs to your visits with the doctors so they can see for themselves, because the radiologist doesn't know you. I'm trying to understand you. And then I use the picture of the MRI to understand the whole drama that's going on inside your body.
So, and there's a term that's used many times. It's MMI, maximum medical improvement. Now, the MMI, my understanding is that if you were to do nothing at all, your body would improve to a certain point without any intervention. Now, do you see people come in and say, "Hey, doc, I don't want injections yet. I don't want injections yet. I don't want injections yet," and they want to go through this conservative standpoint? At a certain point in time, are those same people coming back and seeking an increase in a hierarchy of treatment, or are they just dead fast on that conservative treatment and not really wanting to become more invasive? Because if you look at it at its face, there's two extremes here: people who feel injections are necessary and people who just don't want those to be involved. What would you say to the crowd that is very steadfast against these injections? You hear comments such as, "Oh, I don't want that crap in my body," or "It's going to do more harm than good." The side effects are like those commercials you see on TV. It's an allergy medicine, but it has bajillion different side effects. How do you walk clients through that, in a sense of explaining that, hey, this isn't the worst thing?
So I consider myself a little bit unique because I'm very distrustful of doctors. I'm very distrustful of the whole medical industrial complex myself. My focus is on how can you be the healthiest, strongest, and healthy-minded version of yourself. And none of that has anything to do with doctors. And that's the foundation of how I look at everything. I don't push injections as the only thing or the most important thing that patients need. And I also explain an injection is not something that anyone needs. It's something that is there to help you feel more comfortable. But what is mandatory is focusing on your health, focusing on your strength. If you can exercise and tolerate the pain while you're exercising and continue doing that to slowly get stronger or quickly get stronger, you don't really need a steroid shot. But if you're limiting your efforts to be healthy, if your sleep is impaired, and when you're sleeping, that produces a hormone called growth hormone. It's natural. If you're depriving your healing pathway from all these hormones and proteins that your body makes normally because you're hurting too much, that's when I think it's a good decision to try these treatments, because my principle is minimizing harm, minimizing the dose. And that's why I offer the injection, because it allows that. Whereas taking a pill, which is nothing wrong with the pill either, you're taking that several times a day, and the effects that that has on your body's chemistry is generally cumulatively worse than these injections.
What else are you offering if you're not offering the injections in regards of maybe an alternate pathway to feeling better, getting mobile, and getting back on your feet?
Honestly, the most common conversation that I'm finding myself having with patients is this paradigm of hurt doesn't equal harm. Okay. They want to hear from a professional who is going to first look at them comprehensively, make sure they don't have a condition that can worsen through exercise. Okay. They're rare. And they, but that's the first thing that I'm thinking, is making sure that we're thinking about that big picture. Then it's a discussion about, these factors that we're talking about today, about the healing process, about moving, blood flow, strength, conditioning, following with your therapist, the chiropractor, the physical therapist. I'm big on talking about an epidemic in this country, which is not lifting weights. I think strength training is a huge factor in to address the aging process and age healthfully. And it's also a huge process of, healing faster, and talking about different types of strength trainings and other approaches like yoga. And then the final aspect is mindset, mindfulness, and a healing growth mindset during your recovery phase.
So you talked a lot about different facets to getting better. And it seems like the one thing that rung true in that is consistency. So especially in healing, getting better, in my realm of the world, of the PI side, we see many clients, what I like to say, dabble. Life priorities shift. I get into a car crash and I'm not able to immediately treat. There's a delay. I start and jump into treatment and I think that I'm going to be better instantly. It doesn't happen. I stop treatment because I haven't gotten better. Then some time progresses. And again, my pain has returned. Severity has increased, intensified. I go back to treatment. How important is, and why does it matter so much to be consistent in your treatment? And how do those gaps in treatment affect the long-term outcomes, especially when you're taking a pause, you're jumping back in, you're taking a pause, you're getting back in how you see clients and treat them?
I think consistency is one of the single biggest factors in making a pain that is a temporary problem that goes away after you heal versus a permanent condition. First of all, there is a memory in your body. There's a pain memory, and keeping yourself in pain and not treating that is the best way for you to have a chronic condition. If someone told you, yeah, I go to the gym once a month, but I'm not getting stronger, why is that?
Yeah.
We all know why they're not getting stronger. So there is also this, approach to the stimulus. When you're exercising, you're applying stress to your body. It hurts. Okay. I guarantee after an accident, after a trauma, when you start putting pressure on it and you start stressing it, it's going to increase your hurting. Okay. It's my responsibility to determine if that's a signal that there's something really serious going on, or if this is one of these expected responses to stress and strain. Why do you want to stress and strain your muscles? Because that stress causes your muscles to then respond by getting stronger, right? That's how it works. So if we're inconsistent, we're not getting stronger. If we're inconsistent, our pain is becoming settled in our body, and it's becoming like a roommate, that the more that you let that roommate stay with you and you don't like him, the harder it is to kick that roommate out.
So you mentioned some treatments that before I forget, I want to highlight. You said ketamine and the psychedelic. Talk to me a little bit about those, because you really don't hear about those often. Ketamine, maybe, and if you don't mind, just explaining a little bit to our listeners and viewers about what that is, because selfishly and personally, you hear ketamine, you're like, that's horse. Horses get injected with that stuff, and I'm sure you smile, but that's the grim reaper in the room. That's the elephant in the room. Talk to me a little bit about. Let's start with the ketamine, about how that is introduced, why it's introduced, what purpose it serves.
Sure. So, right, we're talking about the continuum here. We talked about the natural healing phase. We talked about mobility, strength training. We talked about the earlier interventions of reducing pain so you can stay active, right? When we start thinking about ketamine, it's because we're recognizing that as pain becomes chronic and remembered into the body, it's more than just injury. It's the nervous system that has been more sensitized and is remembering and over-expressing pain. So it's now not just a tissue injury problem anymore, or a structural damage problem anymore. It's a nervous system abnormality. And when we've made that decision where we've crossed over that problem of chronic, extreme remembered state of pain, we want to reprogram how the nervous system is processing hurting. So there's lots of different ways to do it through, let's call it consciousness medicine, like meditation or mindfulness. These are natural ways of doing it, addressing the mood. But in my background as originally an anesthesiologist, before I became a pain specialist, I became very familiar with the use and administration of a medication called ketamine. Now, ketamine is a safe, FDA-approved medicine that was FDA approved in like 1971.
Do you want to repeat that for the people at home? Did I hear it one more time about safe?
Ketamine is a safe, FDA-approved medication since 1971, used for anesthesia, for putting people to sleep. The reason why it's so safe, because it doesn't stop you from breathing. It doesn't lower your blood pressure or heart rate. It is so safe in humans for anesthesia that we use it for animals in veterinary medicine. And that's why it's been kind of labeled as like horse tranquilizer, because it's so safe and used in humans, we use it in horses. Now, what had been studied in the 1990s and early 2000s is off-label ketamine at lower doses, where we're not putting someone to sleep for surgery, can cause a altered state of consciousness. We call that a psychedelic effect. If you're not familiar with psychedelics such as psilocybin or LSD, those are the classic psychedelics that are not FDA approved, not legal. So I have never once ever in a clinical setting administered LSD, psilocybin. They are being studied, but ketamine, which
EDM concerts, I believe.
And so ketamine does get lumped into these, illicit drugs, and is also used in an illicit way as well.
Okay.
But in a controlled setting with a physician, this can be safely delivered through an IV intravenously. It can be delivered in other mechanisms as well. I recommend only doing it in a medically supervised setting, not necessarily just for the safety, but to get the maximum best experience, because you can really target the right dose. The effect of it is an altered state of consciousness.
How long does that last for?
My treatment protocol is only 45 minutes. Okay. It's a 45-minute IV infusion. We create a setting that is very healing. We provide music curated using EDM type music that I've actually created this.
Trance. I'm gonna have to get that playlist when we're done. But so once this experience is happening,
Yep.
is this something, if John or Jane Doe came to you and they said, hey, listen, I'm in continued pain, cortisone isn't working, epidural isn't working, radio frequency ablation isn't working, I would like to try something alternative, you recommend ketamine. What is the treatment plan? I know you were touching on it. Is it bi-weekly? Is it daily? Is the ketamine ultimately creating this altered state that traverses into regular day life without treatment? What is the main focus of it?
Sure. So patient selection is key, right? We're not doing this for everyone who has chronic pain. We're doing this for someone who we have identified that the nervous system is in this fixed state. There's also this element of mood and a lot of times with trauma, PTSD, there's these overlapping psychological problems overlapping with the pain. So it's actually two goals a lot of the time with the patient selection. One, trying to lower or turn down the volume of the pain, but also to help with these, secondary depression, anxiety, PTSD symptoms as well. The treatment protocol that I do is once a week for 6 weeks for the specific goal of learning how to train and reprogram through what's called neuroplasticity, which is forming new pathways, not to stop the pain, but to override the pain. When you're having this consciousness expanding experience, it's more than just fun. It's a change in the brain's microarchitecture where new connections in the brain are being formed. Now, just like with exercise, if you work out once a month, you're never going to get stronger. With ketamine, if you have this new connection in the brain and do nothing else, those new connections are going to fizzle out and they're not going to stick. So repeating it, on average, it's 6 treatments per patient. But what I emphasize, just like with the steroid shots and getting stronger, doing uplifting activities, meditation, mindfulness, all these things to really boost the benefits of this new perspective shift to help reinforce those new changes.
What percentage of the patients and clients that you see actually fit the criterion for, or the scenarios fits the pieces together for ketamine treatment?
So I started ketamine because I tend to get referrals of some of the worst of the worst over the course of my career. And so when the standard treatments like exercise, physical therapy, chiropractic, injections, and many times surgery don't work, and we're looking for tools in the toolbox, this was something that I've been treating for many years now. Now that when I see a patient who's brand new from an accident, percentage-wise, that's a relatively low, because I want to get them better through the conservative routes. So it really is a select patient where they've exhausted all these more conventional conservative options first.
And typically in regards to the ketamine treatment, is this usually implemented on a younger individual, an older, or it doesn't discriminate?
It doesn't discriminate. Generally speaking, it's easier to put out a campfire than a forest fire. So when they've been having these problems younger in their life, they're more responsive to these new neuroplastic changes, these new connections. But it is amazing how many 70-year-olds come into my office who've never done any drugs in their entire life, brought in by their kids who are, maybe a little bit more tuned into these types of therapies that are emerging. And I'm getting great results with, elderly patients as well.
That's great. So switching back a little bit to the traditional, I'll donate methods of treatment. There's the cortisone, there's the epidural, there's the radio frequency ablation. Are there any other ones that I'm missing that your practice kind of touches on or will endorse if the pain continues over time?
Sure. So, right, ketamine works in the brain. We can also treat the nerves. And so one of the modalities that I use to treat the nerves is when the conventional conservative treatments haven't worked are modalities such as spinal cord and peripheral nerve stimulators. These are really exciting, cutting-edge therapies where electrical signals are delivered to the nerves, filtering out pain at the nerve level. Another very successful therapy that I do when they've exhausted a lot of options is something called a pain pump, an intrathecal pain pump, where micro doses, low doses of medicine are delivered into the spinal fluid in the spinal cord level, treating pain at the source at low doses. We live in this world where we're very scared of long-term medications because of what we see in the news. My perspective on this, it's very easy for me to separate what we hear about on the news with this fentanyl crisis and addiction crisis that's affecting so many families and someone seeking pain and seeking relief through medications. But the fact of the matter is, when you're taking a pill every day at that dose, it really blunts the natural impacts of your natural function of your body. And in the long run, these opioid medications are shown through science and also my experience to actually make pain worse in the long run. So a lot of my mission is to find alternatives to medications long run for pain management.
So with the clients and patients that you work with, is there, obviously you start conservative and you don't want them to feel pressured. If a client weans and their symptoms exacerbate, then they come back and they're going back and forth. Is there a time period where you sit them down and you say, hey, maybe it's time we up this ante and go to these more invasive treatments? Because it seems, at least through our conversation here, that a lot of it is on their terms, as it should be. There's many, I think we both can accept the fact with a lot of pain management doctors that the insurance is paying the bills. The more money is for the injections or more so the surgery and invasive things. Whereas through our conversation here, you made very clear that you take the opposite effect on that. You want the conservative effect, but you also want to make sure that the client's feeling better. How do you internally decide when those things are appropriate for a client to begin to take the next step outside of the comfort zone of conservative and start to go to more to these battery packs, these epidurals, these radio frequency ablations?
Yeah. So again, going back to my view of being a little bit cynical and distrustful of the way doctors go, I'm here for you, the patient, and too many doctors look at it the reverse way. They might have an agenda of what types of procedures or how many they can do to the patient. And if you get that sense from your provider, that should raise, in my opinion, some red flags. Fortunately, a lot of doctors that, I affiliate with don't have that approach, but that's certainly my approach. I'm here to provide options. I'm here to act in your best interest as a patient. I'm here to listen. When we've exhausted these more conservative, conventional approaches, I don't want to give up on you. So I have these other treatment options that work better for your behalf. So it really is a relationship that I'm trying to build with my patients. Seeing that in your provider really should inform you of does your doctor have your best interests in mind? So
in closing, the one thing I want to talk about is the red flags. It's easy for me to sit here from where I sit and say, like, these are red flags, A, B, C. But for somebody who's respected and in the trenches every day as a pain management specialist. What are some red flags that if there's a listener, if there's a client, there's a patient, we get a lot of walks of life that are listening to this, that maybe that provider's not out for your best interest, that they're not there for you. You touched on one. Is there any other ones that are red flags that come to mind that you're like, got to get the hell out of Dodge? You got to get out of there.
Do they sit down? Do they look at you? Do they seem emotionally in tuned, that you're going through something? You know, are they really trying to understand what your needs are? It is a feeling, right, that you have to get. I also think it's fair to ask and communicate, because doctors, we're human too. We're sitting here, it's January 12th. The Eagles lost last night, okay? I was terrified that I was going to exude this disinterest to my patients. So when they asked me how I'm doing, I told them all, terrible. I'm really in a bad place today, right? So it's also important to, if you're sensing, right, this is an emotional feeling, that your doctor has a red flag where they're not listening or have their interest, I think it's fair to ask them as well, rather than simply just leaving the office, writing bad Google reviews on them, and bad-mouthing them. Maybe they're going through something as well, but I think open dialogue is fair when you feel that, or get that sense that they're not fully understanding your perspective.
Awesome. So this has been a great conversation, Doc. I think what we're going to do is we're going to open it up to the viewers at home. Hopefully some people leave some comments. We do get some feedback on something in particular they want to talk about, the psychedelic, maybe some different other things that you may want to talk about besides the ketamine. How does an individual get in touch with you if their provider, they're at a head, or if they just want to try some pain management treatment that you offer that may not be offered from other individuals? I presume and assume that not every doctor out there is properly trained and administering ketamine as you do.
Correct. So my website is www.phillysmartpain.com. There you can find the phone number to call and schedule an appointment, or reach out to us through those means. I think you want to go to a board-certified trained specialist in ketamine, not necessarily because it might be dangerous, because you want to get the best outcome, and you want to have someone who has a really good protocol that's going to actually have a good impact, sort of like you don't want someone who's not trained in surgery operating on you.
Is there, and before we close off officially, that playlist that you mentioned, is there like 2 or 3 songs that you know off the top of your head that are on that playlist that we can subscribe to or listen to or pull up on YouTube?
So there is a playlist on Spotify called Ketamine Flow.
Okay. All right. I will have to download. Maybe that would be the intro to this show, or at the end we'll fade into the darkness with the ketamine flow. But notwithstanding, this has been another great episode and great conversation. Once again, thank you, Dr. Sam, for being here. As always, www.injurypros.com. You can watch us on where you watch all your podcasts, Spotify, YouTube. Subscribe. Go to the website. Look for anything else that you may be interested in. Drop us a comment, what you want to see next. And thank you, as always, for tuning in.